Three patients are in active crisis. One is hyperventilating through a severe panic attack. Another is pacing, responding to voices no one else hears. A third is compulsively washing their hands until the skin breaks. In an environment where everyone needs immediate help, a psychiatric nurse has to decide who gets treated first and exactly what to do. This blank pyramid shows how those decisions are made. Clinicians don't rely on guesswork or intuition to make that call. Psychiatric triage operates on a strict, universal structural framework. Bypassing even a single level of this specific hierarchy can mean the difference between a stabilized patient and a fatal outcome. At the absolute base of the hierarchy is biological and environmental safety. This scale shows how clinicians objectively assess suicide risk. Vague thoughts of self-harm rank at the bottom, but a highly specific plan with access to lethal methods hits the top, requiring immediate one-to-one observation. That safety mandate extends outward. Under the Tarasoff duty to warn, credible threats against an identifiable person require clinicians to break confidentiality and warn the target. Biological safety also means identifying hidden medical emergencies, like substance withdrawal. Opioid withdrawal is painful, but it is rarely life-threatening. Alcohol withdrawal can trigger delirium tremens, a condition that causes fatal seizures, meaning it takes absolute priority in a triage setting. If a patient becomes an immediate physical danger, clinicians may use physical restraints. These are highly regulated, time-limited last resorts that require a doctor's evaluation within 1 hour and physical checks every 15 minutes. Until a patient's biological and environmental safety is stabilized by protocol, no psychiatric healing can begin. Once safety is secured, the clinician moves to the second level. Here, communicating with the patient is treated as an exact, calculated science. Psychiatric professionals follow strict, counterintuitive rules. For example, they are trained never to ask a patient why. Asking, "Why did you do this?" sounds accusatory and triggers defensiveness, closing off the conversation. Instead, they use silence as a deliberate medical tool. Sitting quietly with a depressed patient provides space to process racing thoughts without external pressure. Navigating psychosis requires a precise professional posture. Clinicians never argue with the reality of a delusion, but never validate it either. If a patient hears voices, the nurse uses a specific two-step verbal formula. They acknowledge the feeling first. That sounds terrifying. Then they calmly present reality. "I do not hear those voices, but I can see you are scared." Therapeutic communication is designed to establish a baseline of trust. It proves to the patient that they are supported without reinforcing a fractured reality. The final tier is where treatment targets the specific mechanics of the patient's diagnosis. For a patient in a state of bipolar mania, the brain is overstimulated. The protocol requires clinicians to reduce environmental lighting and noise while providing high-calorie, portable finger foods to prevent physical exhaustion. In a case of severe obsessive-compulsive disorder, a clinician must never abruptly stop a patient mid-ritual. That compulsion is their only current coping mechanism, and interrupting it triggers panic-level anxiety. During a severe panic attack, the clinician prioritizes physical presence and short, simple sentences. For phobias, the treatment moves to systematic desensitization, introducing the trigger in tiny, controlled steps paired with relaxation techniques. In this third level, the physical environment and the nurse's exact movements are molded to fit the mechanical shape of the psychiatric disorder. Emergency psychiatric intervention prioritizes immediate stabilization over the permanent resolution of an underlying mental illness. Success is measured by the patient's return to their pre-crisis level of functioning, a state known as the clinical baseline. Long-term recovery tools, like cognitive behavioral therapy or dialectical behavioral therapy, can only be implemented after this baseline is restored and the patient is capable of higher-level reflection. This spectrum shows that mental health is not a binary state. It is a continuous continuum that everyone moves along, navigating moments of wellness, acute stress, and severe crisis. Navigating the extreme ends of that continuum requires a delicate medical balancing act, uncompromising safety protocols combined with profound, judgment-free empathy.